20 years from now, it was a dictum that keratoconus doesn't exist in Chinese, for example. And now we see so many cases here. It probably went undetected for so many years. And that's why most of the keratoconus patients that we see here in China, or most of Southeast Asia, except probably India, they are very advanced. Usually presents in the second decade of life. But you'd be surprised how many cases do we see nowadays in very, very young kids. And this has all got to do with a better techniques to diagnose keratoconus. In terms of pathophysiology, there can be genetic factors associated, biochemical factors. There are changes in tear film, environmental factors, and also biomechanical factors. We know for sure that crosslinks in the cornea have got something to do with the pathogenesis of keratoconus. Corneal stroma is made up of parallel collagen fibers, and there are bridges or crosslinks between each of these fibers. And now we know for sure that in keratoconus there is a reduction in these crosslinks. There's a degradation of these crosslinks, which results in displacement of the collagen fibers over each other, and also rearrangement of these collagen fibers, and that is what probably leads to ectasia. And once it starts, it's very difficult to stop, especially if it starts early. Clinical presentation, as I said, is progressive impairment of vision, irregular stigmatism. You can see iron deposit lines, corneal scarring, and acute corneal eye drops. In terms of diagnosis, 10 years from now, OB scan used to be the way to go because it gives you a picture of posterior cornea. But subsequent studies, multiple studies have shown that once you leave the realm of normal cornea, OB scan doesn't work at all. So here comes Scheimpflug imaging, one of the most successful imaging platforms in the past 10 years or so. And Pentacam is by far the most commonly used platform worldwide in all the clinics. Typical topographic images of keratoconus, you can see bow tie, you can see inferior cone, which is actually very common. You can see a picture of PMD, pellucid marginal degeneration, where the thinning is actually between 4 and 8 clock hours. Sometimes you can see central cone as well. And this picture just shows how the pictures, the topo images, they correspond with the clinical pictures in normal keratoconus eyes and also in keratoglobus eyes. But by the time you see this, you really don't need a pentacam or OB scan or anything else. You'll probably be able to diagnose keratoconus just on slit lamp examination and proper history taking. So what we are looking here as it is early diagnosis of keratoconus. Are we early enough? And this is more important nowadays because now we know that we have a modality called collagen cross-linking, which is surely going to be more efficacious if we do it in early stages. And that becomes more important when you see your patients who are in the early 20s. And at least 2 good studies in the UK and Europe have shown that there's a long-term impact on the reduction in corneal transplantation rates once you do collagen cross-linking. So let's look at this Pentacam. The D value is 0.42. So if I ask you with show of hands, probably everyone will say yes, that this case might be all right for refractive surgery. But this is the contralateral eye showing a full-blown keratoconus. So by definition, this is form first. So now if I ask the same question, obviously you can't even touch this eye. All you want to do to this eye is keep an eye doing serial pentacams so that if there's a progression, you'll probably go ahead and do a cross-linking in time. So early diagnosis does matter a lot, and that's why there's a concept of non-tomographic diagnosis. So you have corneal tomography, that's fine, which is fantastic in terms of getting information on posterior cornea, but you are clearly not picking up cases early enough. And when you're looking at early diagnosis, these are the 4 techniques which are at least clinically available now out in the market. You can use them in the clinic. Wavefront aberrometry, very commonly used. Corneal biomechanics, we're going to focus on that. FTIR, not easily available. You can get access to optical quality analysis system, but again, it's sort of questionable how easily you can pick up early keratoconus in these cases. Biomechanical properties are obviously important when you especially use this knowledge with respect to keratoconus, because we know that the pathogenesis of keratoconus and development of treatments for keratoconus is strongly associated with what we know about corneal biomechanics, and this is what you can use to measure the corneal biomechanics. Now, in this list, we're going to focus on Corvis ST, I've had some good experience with ORA, but only in normalized. So ORA has got a good repeatability, reproducibility, but only in normalized. Probably reminds me of orb scan. Once you cross that realm, you don't know what you're measuring. So Corvis is an ultra high speed shine flood camera. It captures corneal deformation response, CDR. More than 4,000 images, image frames are looked at, are scanned per second. It enables visualization and quantification of CDR in response to a standardized air puff. That's how the platform looks like. Basically looks like an NCT machine. So the footprint is really tiny, which is fantastic. That's how the cornea indents once you throw a puff of air in there. It doesn't work, but yeah, obviously, as I said, that's how the cornea will look like. Sorry. Once the puff of air comes in, all right? So you're basically measuring the corneal deformation response to a puff of air, which is very, very standardized. So again, it is very important to know that whatever you are measuring is repeatable. All right, we've had that experience with ORA, unfortunately. So we actually did this with pilot study where we looked at normalized and keratoconus size, full-blown keratoconus, not form first. And we actually found very, very high repeatability in almost all the parameters that were measured with Corvis ST. This is one of the initial studies that we did and published in 2015. We went ahead, and by that time, Corvis had, OCULUS had released more advanced software. So we started looking at deformation amplitude, DA ratio 1 and DA ratio 2. This abstract was presented in ARVO in 2016, I think, and we actually found the AUC, area under the curve, which basically means that the repeatability is fantastic once you're looking at these two parameters when you're differentiating normalized from keratoconus size. Couple of years down the line, we actually published that data. And if you want to look at this carefully, the AUC for most of the Corvis parameters is very, very good. Now at the bottom, you can see DA ratio 1 has an AUC of 937, which is excellent. Anything more than 75 is actually pretty good. Anything more than 80 is already very good. Anything more than 90 is excellent. DA ratio 2 is also 946. So these parameters are actually very, very useful when you're differentiating normal corneas from keratoconus corneas, not form first. So we'll come to that. Let's talk about a couple of things here. Biomechanically corrected IOP or BIOP. Now this is an IOP which is based on FEA, finite element analysis. So basically this is a mathematical number which is generated once you're looking at a bunch of eyes from different age groups with different corneal thicknesses, and then you come up with this number for that particular corneal thickness and age group, which is going to be independent of these parameters. So imagine IOP measurement after LASIK and BIOP measurement after LASIK. So preliminary data, mostly from South Korea, we have our own data, has shown that BIOP hardly changes after LASIK as compared to a Goldman IOP. The second one is stiffness parameter. You will hear more of SP in the next year or so. This basically is measured with hot wire anemometry. It's a relative pressure. The anemometry values are converted into pressure, and this, let's put it in a simple way, that it sort of represents the stiffness of the cornea. The concept of SP was created by Cynthia Roberts back in Ohio. Again, this is telling that SP is adjusted AP1 minus BIOP divided by A1 deflection amplitude in these cases. The other thing that we need to remember is ARTH, which is basically one of the other screening parameters in the new Corvis platform. It is the thinnest pachymetry divided by pachymetric progression when you look at the cornea from the center to the periphery, which is going to be different, as you can see in the picture, in a keratoconus cornea as compared to a normal cornea, which is still thin. So based on these parameters, what Corvis had this Vinciguerra screening report, which is a single interface report using 4 important biomechanical parameters. And this index was renamed as Corvis Biomechanical Index, or CBI. Vinciguerra screening report was based on a data set of 755 patients from Italy, Brazil, and South Korea. Dr. David Kang is right here behind us. He's contributed patients to this initial report as well. So we're looking at highest concavity radius when the deflection happens, inverse concave radius, DA ratio, and deflection amplitude. This is how the Vinciguerra screening report or CBI looks like. These are the normal ranges for dynamic corneal response parameters for each step of that, each millimeter of mercury of BIOP. And these are the standard deviations of these 4 parameters: DA ratio, HC ratio, ARTH, and stiffness parameter 1. And there you have CBI, which is derived from these parameters. So further studies by Renato Ambrosio have shown that the cutoff for CBI is close to 0.5. So if you have a CBI value of about 0.5 or more than that, that cornea is suspicious, all right? So this is the initial publication published in JRS 2016. This is our publication. So in addition to looking at full-blown keratoconus, we actually hand-picked form-first eyes. Form-first eyes were defined, and Dr. Tommy Chan, he's the second author on this. He's going to be speaking next. Form-first eyes are defined by contralateral full-blown keratoconus, and ipsilateral eye would be perfectly normal in terms of corneal tomography. All right. So if you look at this, CBI, it was significantly different between normal and keratoconus and normal and form-first eyes as well. And if you look at the AUC of CBI was pretty much the same as the AUC for BAD for form-first. So if you are looking at D value of BAD, you're not going to be able to pick all the form-first eyes. Once you talk about form-first, BAD is not as sensitive and as specific as compared to a full-blown keratoconus eye. So the ideal dream would be actually to combine the good things that we see on Pentacam with the stuff that we measure on Corvis. So you're looking at a platform where corneal topography combines with biomechanical properties and then gives rise to a single interface which has TBI, tomography and biomechanical index. Now if you look at this carefully, these are healthy in keratoconus patients: DA ratio, integrated radius, stiffness parameter, and ARTH. These are 4 refractive maps derived from Pentacam, and when they're together, you get the TBI, or tomographical biomechanical index. The TBI is calculated using a regression formula. The AUC initial reports for CBI, BAD, and TBI were 986, very good, 999, excellent, TBI, 1, absolute. You can't get better than 1. TBI in 94 form-first eyes had a sensitivity of 92% and specificity of 98%. This is not my data, it's from Renato Ambrosio. Again, the same shown in a graph. So let's again look at that case that I showed initially. So remember the D value is 0.42. Again, show of hands, looks pretty okay for refractive procedure. CBI is already abnormal. All right, TBI is already abnormal. So this is what we are looking at. This is what we desire, to have a single platform which can pick up the best in both Pentacam and corneal biomechanics and give us a single number. This is our unpublished data. Actually, the numbers are a bit better than this, where this is form-first eyes again, not full-blown keratoconus. BAD was 0.75. TBI is actually now more than 0.9. We've added a few more cases. So the results are pretty exciting when you're looking at differentiating normal eyes from form-first eyes. So to conclude, this is the last slide. We definitely think that there is a huge potential for the use of this platform to diagnose keratoconus at a very, very early stage. So this is very, very important in refractive surgery screening. So what we do usually is we screen our patients with Pentacam, but they also get a Corvis screen, just so that we are doubly sure So what we are doing in our refractive surgery screening. This is also helping us to a certain extent in proper selection of cases for collagen cross-linking, especially in cases where we are already on the fence, whether we should do cross-linking now or whether we should see the patient 6 months down the line. So CBI and TBI do help in addition to the pentacam parameters. And of course, in future, this would be useful to look at the efficacy of various treatment modalities if we have a longitudinal follow-up of these cases after treatment of keratoconus with collagen cross-linking. Thank you very much for your attention.